Just recording, so that's good. Kia ora koutou. Welcome everybody to this Tuesday, the 1st of July, our monthly Tuesday webinar on professional issues in nursing, professional issues in research. And we're very lucky today to have with us Jo Borren. Kia ora, Jo.
Kia ora, Lorraine.
And I'm going to just read out a little bit about and welcome, by way of welcome to Jo and background. I've asked Jo to speak today. It's her PhD topic, and that is competence assessment practice in the Bachelor of Nursing programs in Aotearoa, New Zealand. And Jo will tell you a little bit more about that as she gets going. But to say that Dr. Jo Borren is a lecturer in the Department of Nursing at the University of Otago and has recently completed a PhD in health sciences. Congratulations. Jo's research interests focus on the interplay between the clinical and educational environment and the assessment of nursing students, work-integrated learning and interprofessional education. So we're really looking forward to hearing from you, and this is recorded so that if you have colleagues who can't make it today, Trish will circulate a link later on. Kia ora. Thank you, Jo.
Thanks very much, Lorraine, for the warm welcome. Kia ora koutou, ko Jo Borren toko ingoa. So as Lorraine said, my name's Jo Borren and I work for the Department of Nursing at the University of Otago, and I'll be presenting today on my PhD research that looked at competence assessment practice in the nursing programs in Aotearoa, New Zealand. So I'll just share my screen. There we go. So hopefully you should all be seeing that now.
Yep, that's perfect, Jo.
Great. Okay. So this research has been undertaken part-time, commenced in 2018, and with my PhD supervisors, I just would like to acknowledge them, Associate Professor Eric Brocht, Associate Professor Kathy Andrew, and Dr. Kay Milligan. And although these slides, I've used a template from the University of Otago, I actually conducted my PhD and it was undertaken through the University of Canterbury. In terms of the structure of the presentation today, I'll first be going through the rationale for the research, talking about the research purpose and design, looking at the unique contribution and important findings from this research, thinking about and discussing the priorities for direction of assessment and learnings from the research process and current research outputs. So in terms of the rationale for the research, at the commencement of this research, the Bachelor of Nursing program was offered at 17 tertiary institutions in New Zealand, and there was no standardised method of assessing clinical competence of nursing students. No mixed methods research has been conducted that compares the experience of competence assessment between nursing students, clinical lecturers, and nursing preceptors. This was a national study, so all programs that offered the Bachelor of Nursing program in Aotearoa, New Zealand were invited to take part in this research. That was except for my current place of employment at the time that interviews for phase 1 were being conducted due to a conflict of interest. I was working at a different institution that did offer an undergraduate nursing degree program, but participants from that institution were invited to take part in the phase 2 survey. So the research purpose, the aim was to investigate the assessment of clinical competence in the undergraduate Bachelor of Nursing programs in New Zealand with the purpose of identifying current competence assessment practice. The overarching research question was, what are the competence assessment practices in the Bachelor of Nursing programs in Aotearoa, New Zealand? And this was investigated with further sub-questions. So I was looking at what methods are currently used to assess clinical competence in the BN programs. How are the Nursing Council New Zealand competencies for RNs used to inform competence assessment practice in undergraduate nursing education? How is competence assessment constructed to reflect student progression in the different year levels in the Bachelor of Nursing programs? And finally, how do nursing students, clinical lecturers, and preceptors experience the processes involved in competence assessment? So, the research design was a multi staged mixed methods framework. There were three phases. The first phase was qualitative key informant interviews. So, I interviewed participants from 9 different tertiary institutions around New Zealand. And those qualitative key informant interviews, the focus of that phase was looking at how institutions are currently conducting their competence assessment, and the interviews were conducted with individuals who sat in clinical manager or clinical coordinator equivalent roles at the different tertiary institutions in New Zealand. This then followed up with phase 2, which was a quantitative descriptive survey. And this was a national survey that went out to clinical lecturers and clinical and nursing preceptors and nursing students throughout New Zealand. This was then followed up with the third and final phase, which was qualitative semi-structured interviews that were conducted with those 3 participant cohorts. So with the nursing students, the clinical lecturers, and the nursing preceptors. So in the first phase, there were 9 tertiary institutions in New Zealand that were involved, and thematic analysis was undertaken on the interview data. That analysis resulted in 3 key themes: so clinical assessment pedagogy, measure of competence, and relational assessment practice. I don't have time today to go into all the detail in relation to each of the 3 phases specifically, but this particular phase has been published. It is in an article in Contemporary Nurse, so you could look that up if you would like further information on this phase, or alternatively email me. The second phase was the surveys, and there were a total of 708 survey responses. So I had 261 nursing students, 286 preceptors, and 161 clinical lecturer responses. And then I undertook descriptive and inferential statistical analysis on the survey data. And that phase 2, an article has just been submitted on the findings from that phase. And then phase 3 was the semi-structured interviews, the follow-up interviews with nursing students, clinical lecturers, and preceptors. And I undertook thematic analysis on the interview data, and that resulted in 4 key themes: structure of competence assessment, te tiriti o waitangi and cultural safety, divergent views, social capital, and workload and resource. So, with a mixed methods research project, one of the key components of mixed methods research is the integration of the 2 strands, the qualitative and the quantitative strand. So, without the integration, it's really a multi mode research as opposed to a mixed methods research. So, the integration component is essential. So, in mixed method research, integration has been defined as the linking of the qualitative and quantitative approaches and dimensions together to create a new whole or a more holistic understanding than achieved by either alone. So in this particular research project, it was phase 2, this quantitative surveys, and phase 3, the qualitative semi-structured interviews, that I then analysed through the integration process. So without integrating the qualitative and quantitative components of a mixed methods research study, valuable insights may be missed or inappropriate conclusions drawn. And the purpose of doing the mixed methods research is really so that you have a breadth and depth of understanding in terms of the topic of study. So with this research project, there were different levels of integration. And so the design itself was an advanced framework multi-stage mixed methods. And I integrated through connecting, which involves selecting interview participants from phase 3 from the participants who had been involved in the phase 2 survey. The results from phase 1 interviews helped to inform the data collection survey for phase 2. And in phase 2 and phase 3, I then brought the data sets together for analysis and comparison. I used a staged approach, so the findings in my thesis from phases 1, 2, and 3 were analysed and reported independently and then integrated in the discussion and also within a joint display. So this is the example of one page of the joint display. So it shows how I have 3 participant cohorts, the students, the preceptors, and the clinical lecturers. I've gathered both the quantitative and qualitative data from both. And then an important component of a joint display is to also identify the fit of data integration. And so the fit can either be confirmation, so that's where quantitative and qualitative data are aligned, or expansion, so new insights are developed through the integration process, or discordance, whereby there's a misalignment between that quantitative and qualitative data. One of the key components of the joint display, though, are the meta-inferences, which you'll see down the right-hand side there. And they're basically what the findings are following the integration of the data overall. So they're sort of like the gold that you're mining for when you're doing your mixed methods integration. So this section or this slide is really just showing one example, one page of a joint display that's looking at all the separate questions that I asked throughout the research. So this one's looking at if participants, or it is clear to participants what sort of evidence they're required to provide their demonstrating provision of culturally safe care. So, like I said, the meta inferences are the gold nuggets of the overall mixed methods integration design. So the meta inferences, or some of the key meta inferences that came out of this particular research study, were that students and preceptors identified that students could be better prepared for competence assessment by the academic institution, and that lecturers may be unaware of this sentiment and feel that adequate preparation is provided. Both lecturers and preceptors identify that further preparation for their role in competence assessment would be beneficial, and preceptors are less likely to feel supported in their assessment role than lecturers are. There is a higher percentage of students that felt better prepared. Oh, yep, we've talked about that through their clinical placements. And this supports the view that clinical areas and students are feeling that students are underprepared for competence assessment prior to commencing the clinical placement. Nursing students query how meaningful the assessment is when students are simply copying each other's examples. And the data from this research shows that that is quite widespread. And the majority of students reported that they felt confident in what is good evidence to show that they meet the competencies. However, students also voiced concerns around the way that their competence was being measured through the provision of written evidence, and queried if this was a robust assessment method. All 3 population cohorts acknowledge and have experienced inconsistency in competence assessment practice. Students discussed variation in assessment expectations being very dependent on the assessors involved in each clinical placement area, and discussed the challenge of trying to identify what these expectations might be for each placement. None of the population cohorts, so nursing students, preceptors, or clinical lecturers, could identify any major differences in assessment of competence between year levels. Variation in terminology between institutions was identified as a challenge, and there was also recognition that there is risk that students are being assessed against the competence of a registered nurse experienced in the clinical placement area, as opposed to the appropriate level for a nursing student experiencing the clinical placement for the first time. 1/3 of each of the population cohorts, and I guess it's significant also to say that there was no statistically significant difference in responses between population cohorts for this. So 1/3 of each of the students, lecturers and preceptors were unclear as to the evidence students require to demonstrate that they are meeting the principles of the Treaty of Waitangi in their nursing practice. So this represents a third of the nursing workforce who are involved in competence assessment, being unclear as to the evidence required to adequately meet this competency. And this is significant because we're talking here about registered nurses in practice who are signing off as meeting this in their registration, but also who are working with students and guiding students in terms of their understanding of how the principles of Te Tiriti o Waitangi can be met in nursing practice, and likewise for clinical lecturers. And if clinical lecturers and preceptors are unclear, then it makes sense that nursing students would also be unclear as they're being guided by these, people within these roles in terms of their understanding. It is evidenced, or was evidenced, that students' motivation for working with Māori and applying the principles of Te Tiriti can be driven primarily by a desire to meet their own needs, so to meet the requirements of the competence assessment. And these findings describe the structure of competence assessment as being set up to engage with both cultural safety and meeting the principles of Te Tiriti in a tokenistic manner. One of the key things, I guess, for me in relation to this research, and one of the key motivators, was to incorporate the voice of the nursing students. There has been some research undertaken previously in New Zealand looking at the competence assessment process from the perspective of clinical lecturers, so those employed by tertiary institutions. But there has been no research undertaken that has incorporated participants from the three key roles of the people who are involved in competence assessment, and also including of nursing students. And internationally, there's much fewer studies undertaken with nursing student participants included in them as well. So I felt it was really important to honour their voice in this process. So I've taken some excerpts out of and some quotes from the data to share with you today. I have quite strong feelings about my experience at the school and how unprepared I actually felt for clinical practice as a nurse. So I think having a lot more role play and scenarios around each of the competencies to show how they actually relate physically to life in the workplace. They probably only went through it once to explain what each of them meant, but there was no real correlation toward how that might look in clinical placement. I think for me, it was always the reality. The floors were so busy, the nurses were so busy. They really had very little time to say, oh, that's a good one for that competency, or you really showed that in that client interaction. I never found I got that back from any of the nurses I worked with. They did go through a moderation process, but that was of dubious validity because they would only go through the moderation process after your clinical lecturer had met with you and told you how to fix your examples up. I definitely found this with my peers and colleagues as well, is that there was definitely an element of you never wanted to put yourself too high in the self-assessment, and you never wanted to be quite truthful because you'd hate to be in the position where you had rated yourself quite high in a certain area only for that nurse to then be like, oh, you're probably only just meeting it there. Now, this is a finding that didn't actually align with international literature whereby students' self-assessments were more likely to be rated higher than what lecturers or preceptors would rate students. Whereas in this research and in New Zealand, and likely potentially due to a cultural difference, students are more likely to report themselves in terms of self-assessment as opposed to over, I guess, grade themselves. The idea would be that they would always feed back to that one single point of information. That was the CLN, that stands for Clinical Liaison Nurse. That's in a DEU model format. Sometimes that would happen, sometimes that wouldn't. It was fairly loose. We'd often have a multiple different preceptors because of shift work. Usually you'd just pick up a seniorish nurse that you'd worked with quite a lot, got their consent and say, hey, would you mind signing my form? They would run through it very quickly and just be like, yep, you're good. There's no red flags here. Then they would sign the bottom of the form. They probably only went through it once to explain what each of them meant, but there was no real correlation toward how they might look in clinical placement. I've heard this from nurses as well. The people who are better at writing do better in their PDRP. It doesn't actually show that they're a fantastic nurse. It's just a measurement of how well somebody is able to articulate in written form the evidence that has been provided. But I can't remember any proper examples where we sat down and talked about the assessment. Oh, yes, we've mentioned that. And it seems like a year one's work could get by in year three if they just changed up their examples and reworded some sentences. There were, I think, a few complaints from other students. They were like, oh, we never see our clinical lecturer. She pops in once in a blue moon for 5 minutes, waves at us, and then just says, any questions? We all go no, even though in our heads we're going, yeah. Then she'll just walk off and we won't see her for 3 weeks. So there was a little bit of that going on. We sat down for the competencies and talked over them in about 2 to 5 minutes and then spent the rest of the half an hour or so just talking about cricket. There wasn't always a lot of professionalism being demonstrated and modelled by the people who are marking your work. So it was really evident when students noticed variations between assessors, and also students were very aware when they weren't getting or gaining the experience in terms of time with the clinical lecturer and placement, or feedback from the preceptor, for example, that they were very aware that that was happening. I think every nurse knows the reality that the floors are madness, whether it's primary care or mental health, because it's such madness, they should prepare their students better. I could never get someone to admit that what they teach us is best practice and what actually happens on the ward are two different things. I remember the one Māori patient on the ward would get swamped by student nurses all asking, please, can you be my patient? Some of them took it really well, and others were like, what the heck's going on? Why does everyone suddenly want me to sign bits of paper? Because everyone is magnetized to them. They're like, oh, you're Māori. And this really speaks to the motivation for students being and their behavior being quite assessment driven, and really thinking about whose needs are being met here. So, in terms of summarising the important findings from this PhD, it was a nationwide multi-stage mixed method study. A third of participants were unclear regarding demonstration of the principles of Te Tiriti o Waitangi in nursing practice, and there was tokenistic engagement with cultural safety. There was a gap evident between Nursing Council New Zealand education standards and what is occurring in practice, and copying and pasting evidence from peers and previous placements was also evident. Writing skills in this assessment are privileged over the experiential demonstration of clinical practice, and developmental progression of professional skill and knowledge through the 3-year program is not currently reflected in the assessment process. In terms of research outputs, throughout the PhD journey, I presented on different phases of the research, and then I've published phase 1, and phase 2 of the research has just been submitted for publication, and I'm aiming to also publish phase 3 and the mixed methods findings too. So just would also like to acknowledge again my PhD supervisors, Eric Brock, Kathy Andrew, and Kay Milligan. I'm super grateful to the participants of this research, without whom this research would not have been possible. And I guess that's one thing I think I was really fortunate with. Sometimes with research, the recruitment phases for research can be quite challenging, and that is not something that I experienced on this journey. And I think it really speaks to the recognition of how, I guess, passionate people are about their role in competence assessment and nursing education. So throughout each of the phases of this research, I had a really high level of engagement in terms of recruitment. And for example, out of the 708 survey responses, there were a third of those participants who requested a follow-up interview. So obviously I wasn't able to interview, 230 people, but it really did just signal the interest in the research area. I'd also like to thank my colleagues at the University of Otago and my previous institution, the Aotearoa Institute of Canterbury, for their support throughout the research journey. It's been a part-time endeavour, and I'm very pleased to have now completed it, but it is quite a significant undertaking. And my family and children, who have also obviously sacrificed in terms of time while I've been undertaking this research. And that is the end of my presentation. So thank you very much, everyone, for attending and for listening. And I hope that you have got something out of it. And I am very happy now to take any questions.
Kia ora. Thank you, Jo. That was fantastic. And just please do put any questions in the chat. And I can't see it at the moment, so I'll just start off, Jo, if that's okay. Firstly, I'm really impressed at how you brought together all that huge amount of data, the integration of data from all those different levels. That's really impressive. Managing it. It's over 700 survey responses is a lot. Of course.
Yeah.
And the other thing I was wondering, so I should know this, but so we've transitioned to standards of competence for registered nurses. Have the nursing student competencies, have they changed since you've done this research?
That's a really good question, Lorraine. Thanks for asking that. So this research was fascinating because in 2018, when I started conducting it, there was obviously the whole journey has progressed through a period of sort of unprecedented change in terms of nursing education. So that is in relation to the competencies, as you mentioned, and also in relation to the establishment and disestablishment now of Te Pukenga, and the development of a national nursing curricula, for example. So there has been a lot of political, I guess, the climate politically has been a very interesting one to navigate throughout this research journey. So, and as you have commented on, the Nursing Council have released their new competence indicators and standards. And so for nursing students now, moving forward, as tertiary institutions, we need to be assessing against those PO as of next year. So they'll be introduced. So the University of Otago here, for example, we have postgraduate nursing, and one of our programs is a pre-registration program for graduates. And so those students will be being assessed against the new PO and competence descriptors as of next year.
Yeah, interesting. So, and that in turn makes me wonder if that will make a difference in that the new PO are more responsive to things like, I guess people are still having to give us examples and so on, but te tiriti and cultural safety much more weighted that way, as I feel they should be. But it will be interesting. And my other question, I'll just see in case I can't see any others, so I'll carry on, Jo, for a minute. My other question is: have you presented this back to the industry, to the educators?
Yes, yep. So part of my dissemination process is presenting back to the industry, as you say. So I've obviously connected with Nursing Council and have done so along the way in terms of this journey, and also at the Nurse Educators Conference, Australasian one, and I'll continue to reach out to obviously different institutions who might be interested in connecting around competence assessment and the process as they undertake it, and what could potentially strengthen the process for their programs or improve I guess really what we're looking at doing is ensuring that the assessment is as valid and reliable as it can be.
And did you have a sense, Jo, when you have presented back, so with maybe informal feedback and so on, that people were not surprised by your findings, or?
I think that a lot of people, when they've heard about the findings from this research, in some way can relate to some of the data that has come through. Some of it has probably been a little bit surprising in relation to, I guess, the tertiary institutions themselves thinking about ways to strengthen the robustness of the research and ensure a moderation process is undertaken for competence assessment. And I guess the data around the copying and pasting of examples of evidence. And also, obviously, what I haven't mentioned along this process is also the introduction, as we're all grappling with in tertiary education now in relation to AI and how that's going to make a difference in terms of this competence assessment process moving forward. So I think that from the feedback that I've had, people who sit in each of those assessor roles, they could relate to the data that was coming from that particular participant cohort, but perhaps didn't have the awareness of the experience of it from another lens, which is what this research obviously shows.
Thank you. And of course, there's that talk in your findings about copying each other's assessments, but let alone AI. There is a comment, I think, can you see Jane's comment in the,
Can we look here?
Shall I read it out and you can?
That would be great. Yeah, if you could read it out, that'd be good.
So Jane Wilson says, "Kia ora, Jo, what an important piece of research. Thank you for an excellent presentation. There are a lot of learnings for us in clinical practice, and I'd be really keen to see how this could be shared and informed where we go from here in student assessments." Yeah, I think that would be great. Would you be keen to get in front of the National Chief Nurse Group? And that's from Jane.
Thanks very much, Jane. I really appreciate your positive feedback. I would be more than happy to present this research further. So if you would like to get in touch with me, and we can arrange a time to suit.
Sounds great. Thank you. Thank you, Jo. Is Jane saying thank you? So she'll get in touch.
Perfect. That sounds excellent.
Great. Anybody else? Is there any? Oh, there's another one, Jo. And that's from Bronwyn. I think that will be Bronwyn, who's the manager of our PDU.
Right, yep.
Professional Development Unit is thanking you. Great work. And Lucy Prinsloo, who's the acting nurse manager. Sorry, Lucy, if I've slightly got that title wrong, but in charge of the Southland Hospital Nursing. Thanks so much for this valuable research. It's important to know how to support the undergrads more. Yeah, I think there will be a lot of people, thanks, Lucy, who are keen, because some of the things you've said there actually ring true from when I was an undergraduate nursing lecturer going out to visit students way back, and we were only allotted an hour per week or something.
Yes.
So some of it was institutional requirements or restrictions, if you like. So that was always the triangle between clinical lecturer, preceptor and student is a tricky one. And that's maybe where Jane's talking to how can we get better or help with that?
Which I think is so valuable. And I think that what has been great in terms of what I've learned through engaging in this research area is that generally speaking, people who work within the roles, whether they be employed by the healthcare workforce or whether they're employed by the tertiary institution or whether they're the nursing student themselves, are all really keen to support this process to be the most robust process that it can be. And a lot of it does come down to the relationships and the relationships with each other, the relationships, at the governance level, and the relationships between the clinical lecturer and preceptor and nursing student. So, and hence, therefore, why one of the themes that came out of this research was relational assessment practice, and the impact of that. So that makes a big difference too. Tightening up process, and there's some really quick and easy wins that can be made through just simply streamlining or standardizing process that I think in terms of connecting with people, industry and also other tertiary institutions, that is something that could really help this process. Which is where I guess Jane's suggestion in terms of disseminating further would be really helpful. Yeah.
That's great. Oh, kia ora, and thank you very much. I think that's all from everyone. And thank you everyone for attending, and particularly to you, Jo. If people wanted to get in touch with you, Your will be jo.borren@otago.ac.nz.
Yes, that's correct. Yep, just my
Yep.
email address there.
Okay.
Thanks, Lorraine.
And I'll have further contact if anyone wanted to as well. Lovely. Well, thank you. That was awesome. Kamu te wehi, and see you again soon. Thank you, Jo.
Kia ora, Lorraine. Thanks very much, and thank you
Kia
very
ora,
much for the
everybody.
opportunity. Cheers.
Ka kite.